Yeah, as I say, it's my pleasure to welcome Craig. He's coming to us all the way from Vancouver, where it's 4:30 in the afternoon. Is that right, Craig?
Yeah, 4 o'clock.
Yeah, that's quite civilized. That's good. So Craig's name, as many of you will know, is synonymous really with multi-criteria decision analysis and program budgeting and margin analysis. He's applied these techniques widely and written about them extensively, including a book, the Priority Setting Toolkit. I'm not sure if you've got a slide to promote that as well, Craig, but I've done it for you now, so that's good. So as well as his position as a professor in the School of Population and Public Health at the University of British Columbia, as you can see, he's a managing partner in Prioritize Consulting, which offers support to decision makers. And so with that, I'll hand over to Craig. Thanks, Craig.
Great. Thanks very much, John. And it's a real pleasure to be here with you folks this morning, your time, and really appreciate the opportunity to speak with you, and look forward to running through the slides. But certainly this can be interactive. So just as John said, please drop questions in the box, and we'll have lots of time for questions once I finish the running through the slides as well. So what I really hope to do for this session is to just talk a little bit about some background on priority setting, and it's a topic which, as John alluded, is near and dear to my heart, but I think it's quite applicable within the broader health services research context, and so we'll bring people up to speed on not only some of the approaches we've used and some of the activities we've been advancing in the field of priority setting the last decade or so, but hopefully we can get into some particular challenges like that of disinvestment, which is a hot topic. I know there's been fair bit of discussion in Australia about the aspects of disinvestment of late as well, and some of the research that's been coming out from your country. So we can cover that in a bit of detail, and as well, hopefully, we'll get onto a case study or two as well, and can show some of the practical aspects of the process, not just the theory. So just by way of background and just one step back from details on priority setting and resource allocation, I'm sure many of you will appreciate that across the top 20 industrialized countries, we see health expenditure ranging from between 7 and 18%, obviously with the US at the top end of that spectrum. And interestingly, we've seen after considerable year-on-year growth in most of the OECD countries, we're starting to see some declines in the rate of growth for year-on-year expenditure. And this is on the backs of negotiated lower prices on products, certainly stronger negotiations from government on wages and reducing salary year-on-year increases. We're seeing obviously hospital budget constraints where the large proportion of healthcare expenditure is typically found, and greater cost shifting to out-of-pocket expenses. And so on the back of that, in many of these countries, we're seeing that year-on-year growth, which was considerable for a lengthy period of time, starting to even drop down in some cases to negative growth, or in many cases just barely keeping up with inflation at that 1 to 2% year-on-year rate of increase. So the long and short of that message is really just that there's limited resources in the system, and that notion of resource scarcity is starting to bite all the more. So I love this quote because it's kind of a justification for what I've done the last decade in the field of priority setting and resource allocation, to say that from the OECD that there's no health system that performs systematically better in delivering cost-effective care, and thus it's not so much the type of system that matters, but rather how it's managed. And I love that because it really speaks to what I think is the piece de resistance of healthcare management. It's looking not at the political, let's see how we can reform, let's see how we can reorganize, let's see what we can do to move the deck chairs on the Titanic, but rather to say, regardless of the system, regardless of how we're structured, we have to figure out how best to allocate the limited pot of resources that we have within a given context. And so, as I say, that really then points to, well, what are the methods for priority setting and resource allocation? What ways can evidence be drawn into and support decision makers in this important activity? A close colleague of mine, Cam Donaldson, a health economist from the UK, on a paper wrote that talk of crisis and calls for more funds obscure the fact that scarcity is a normal condition. Resources devoted to one service are of necessity not available for other services. And that's just pointing to the fact that there's an opportunity cost around every decision that's made. And those opportunity costs are often not as explicit as we would like in the health service. And so then again, the question is, if we're talking about how best to allocate resources within an envelope of funding, and we can acknowledge that opportunity cost is a real principle that every decision maker faces, then the questions become, well, what do we do about that, and how can we advance the discussion around priority setting and resource allocation? So when I use these terms, I'm really talking about a set of methods for making difficult decisions about what to fund and what not to fund. And I see that happening at many different levels within the health system. It can happen at the level of a state government. It can happen at the level of health authorities or health regions, certainly at hospitals, community care agencies, individual programs or individual services. What I'm not talking about here in this talk, and what my program of research does not typically address, is that of bedside rationing. And John and Sarah, I'm just going to apologize because I sit at the Vancouver General Hospital, and outside of my window is where the heli pad lands, and Helijet is just landing at this very moment. So I apologize if you guys are picking up a substantial amount of background noise there. So I'll just keep talking, but please flag if it's too loud, and I can try to move to another room quickly. So what I'm not focused on in this talk is the level of bedside rationing. So thinking more about policy decision making and strategic priority setting at the different levels that are listed on the screen, but not so much that one-on-one clinical bedside rationing interaction. So what's typically done at that policy level? Research has shown that historical and political allocation is the norm. When I talk about historical allocation, I'm referring to funding decisions are being based largely on last year's budget with some adjustments. Those adjustments can be indeed political, at points demographic, at points what's in the media and what's drawing the public's attention. And those types of approaches, which as I say, are certainly the most common in the health service, not only in countries like Canada and Australia, but in the UK and New Zealand and many other countries. We see the squeaky wheel getting the grease. We see government mandates that, in a sense, trump what local decision makers are trying to do. We see on the back of this kind of historical and political allocation continual growth in budgets whereby opportunity costs are not explicitly addressed, and whereby decisions around reallocation tend to be less important or less at the top of the mind than where we can get more money and how we can grow our program. So it's a real challenge that I think inherently leads decision makers to not getting at explicit methods for assessing opportunity cost and looking at reallocation. And we've done surveys in many countries, including Australia, whereby many decision makers have indicated that they're uncertain about the tools and the methods available to them with respect to priority setting. And John alluded to my book, Priority Setting Toolkit, and that's exactly why Cam Donaldson and I wrote that book over a decade ago, was to have a set of tools and processes and methods that were at ready hand for decision makers, bit of knowledge transfer to say, hey, there are methods available. You guys need to pick these up and be more explicit about the activities on priority setting instead of relying on that historical and political allocation process. So over the last decade or so, I've had the good fortune, while I come from a health economics perspective, I've had the good fortune of interacting with bioethicists and in particular folks like Jennifer Gibson at the Joint Center for Bioethics at the University of Toronto, whereby we've really come to acknowledge and recognize and try to push the literature around the need for priority setting and resource allocation to be informed by both of these disciplines. And in this context, what I'm thinking about really is for economics to bring that lens of value for money, how to get the right allocation to optimize the budget, optimize that envelope of funding available within a given context. And on the ethics side, the interest there has been around ensuring that there's a fair process in the decision-making activity. So ensuring that the process is as transparent as possible and is done in a manner which leads to a perceived legitimacy. And the argument there is that sometimes it's really difficult to get the quote-unquote right decision. And so the stakeholders are more likely to agree on procedurally fair activity leading to some set of decisions. And it's this ethics and economics being viewed as complementary, which I think has been one advance that my group and folks like Jennifer Gibson have contributed to the literature. I like this because health economics, and in this context, ethics and priority setting are really all about trade-offs. And so the caption, honey, did you want the one that cures headache and causes stroke, or eases back pain but causes heart attack? And it's just to acknowledge that trade-offs will be made. And it's important then to weigh out the costs and benefits together and apply that knowledge within a systematic framework for determining how best to allocate those limited resources. And so if I could, summarize a research program in one slide, it would be this, as simple and straightforward as possible, noting that there's many layers obviously behind these 6 bullets. But the way I've gone about this the last few years in advising organizations and certainly through the research we've done in my research group, looking at, first off, identifying stakeholder values, and out of those values, constructing a set of decision criteria, and upon the basis of those decision criteria, rating, ranking, assessing options for investment and disinvestment. And we'll go into more detail about some of those terms in a moment, and certainly we'll get into more detail about multi-criteria decision analysis. But that is really the essence of the work, to assess the relative value of options for change within a given context on the basis of a set, predefined, established set of criteria to allow for that relative value trade-off. The process absolutely has to include validation, communication, and in essence, and I often will use this slide when I'm speaking to public audiences to say, at least in Canada, and I imagine it's the same in Australia, that the public doesn't like to accept that there needs to be winners and losers. But yet, when there's a limited funding envelope, that's exactly what this is about. And so it's about minimizing the benefit loss around those who are on the losing end, and it's about maximizing benefit for those who are on the winning end. And there's no other way around this. And I do get a little bit tired when sometimes decision makers try to put forward everyone can win, or yes to you and yes to you and yes to you, and in reality, I think that's really a dangerous take, going back to where I started on this presentation with respect to the growth year on year being constrained, and really just the challenges that we're seeing in the health service with respect to resource constraints. That the fact that choices have to be made means that there will be winners and losers, and so I think we as a health services research community can do more work in terms of educating the public around that very point. So that last slide was the overview, and indeed there's a lot more to it, and I'd like to get into a bit more of that over the next few slides. So this is a slide which I've put into a couple different papers over the last few years, and I've tried to describe in a little more detail what program budgeting and marginal analysis, PBMA, as well as accountability for reasonableness, A4R, that's the ethics piece that I was speaking of a minute ago, and MCDA, the multi-criteria decision analysis bit of the process, all can be kind of encapsulated in these 8 steps. So the way my group has been doing the priority setting work over the last few years is to first off define your aim and scope. So what's the organizational context, and what are you trying to do with the exercise? Is it strictly a disinvestment activity because the budget is constrained and there's deficits within a given organization, or indeed is it about reallocation and being able to say, hey, how can we move resources from one area to another area in order to optimize and maximize the benefit gain for the limited resources available? The second step is to form an advisory panel, and that could be, a senior management team within a healthcare organization, or it could be some delegated authority within an organization, which necessarily should involve clinicians, managers, finance folks, decision support and data folks. At points, it can include members of the public directly on an organizational advisory panel. And that advisory panel really has a couple of key steps. The first is to figure out where resources are currently being spent and what those spends are producing in terms of a set of outputs. And obviously in our lingo, we want to get to outcomes, but acknowledging in many healthcare organizations, they are stuck on outputs. And so needing to look at how inputs and outputs are linked and spending some time to consider, hey, what's the benchmarking say about where we are as a given organization? Where's the clinical variation, and how's that speaking into our inputs and outputs? What are some of our key metrics that are available within the organization, within administrative data sets, and how can those start to raise some flags around where resources might be shifted, and how that initial generation of ideas for where resources could be shifted could come from. So that's the program budgeting bit. And then the bottom half of the slide refers to the multi-criteria decision analysis. So that advisory panel, their second major task, once they've had a look at the program budgeting activity, is to say what are the criteria upon which we're going to assess the relative value of options for investment and disinvestment. And then going out for a call within an organization to say, right, what are the proposals that we're going to look at? And there's many different ways to do that, and I won't get into a huge amount of detail about that here on the call unless we want to get into it with some questions. But just to say that, that can be a top-down approach, it can be a bottom-up approach, it can allow for massive clinical engagement if done well. And the point there is really to look at options for change within the existing spend. So identifying areas that have perceived higher value and putting forward an evidence template, a small business case, if you will, that speaks to the relevant criteria and allows for that advisory panel to rate and rank those proposals, again, both for investment and then similarly for disinvestment. And some folks have spent, as I mentioned earlier, some time on constructing and conceptualizing disinvestment. So I'll come back to that piece in a few slides. I won't take the time at this moment to get into detail on that. And then the third piece at the bottom there, decisions and rationale. So for that group to, once they've gone through the proposal assessment, proposal generation and then proposal assessment phase, to come up with a series of recommendations and communicate well the rationale for those decisions. Having an appeals process built in whereby if there's been errors or procedural issues to allow for an appeal that could come forward. And then to set the whole process within an evaluation and improvement lens. So I typically will go into an organization and will say you probably won't get it 100% right in the first go, but even if we can get 70 or 80% right, we're going to be far better off than that historical and political model that's likely in the organization. And so we start to move along the way of an explicit transparent process like this that's based on an evidence base through submissions of business cases. It's based on key criteria that reflect the objectives of the organization and hopefully the underlying stakeholder values that are relevant for the given organization, and allows that organization to move towards this notion of shifting or reallocating resources, not just tied to the budget cycle, but on an ongoing basis. So building capacity within health service organizations and allowing for, on an ongoing basis, assessment of how resources could be shifted or reallocated to get more benefit overall. And again, that key bit for MCDA is having a robust set of criteria, which is in essence as a whole, the construct of benefit upon which proposals for change are being evaluated. So the key concepts, have you have a look at that while I have a sip of water. We're getting at reallocation of resources. At times, incentives are required to encourage participation. You can't do this without clinicians working alongside of managers, and some of the work that my group and other colleagues have written on is specifically around how we can engage physicians in this type of activity, and it's a chore. It's not always easy, but when physicians in particular are brought into this type of activity, it's really quite amazing, the leaps forward for an organization that can be observed. Those ethical conditions that I've mentioned are built right in. The notion of transparency, the notion of having an appeals process, having strong communication, having a relevant set of criteria, and having an evidence base built in. All of those aspects of an ethically based process for priority setting will lead to fairness in the priority setting process, in the decision-making process, and as such have a greater perceived legitimacy, so that at the end of the day, people involved or people not involved will be able to look back and say, you know what, actually I'm kind of ticked because these decisions didn't turn out in favor of my program area. However, I respect the process. I saw that the process was legitimate. I understand how that team got to those recommendations. I can accept it. I can live with it, even if I don't like it. And that's, to me, a really rewarding place that we can get in our organization to. And not to forget that this is just a tool. That's why I call it a part of the toolkit, right? It's just a tool within the manager's set of processes, policy, instruments that can help shape how an organization is moving forward. So a bit more time on the criteria, because it's such an important part of the process. Essentially, I look at the criteria as the means of operationalizing the organizational objectives. So every healthcare organization has its vision, its strategic plan, and out of that strategic plan will be a set of key objectives. So on the back of those objectives, we're developing a set of granular, clearly defined, measurable in as much as possible set of criteria which allow those proposals for change to be assessed. And I said, no, if maybe you're not familiar with MCDA as a term and haven't heard of a multi-criteria approach, this is an approach that I wish I had invented, but I certainly didn't. It's widely used in both public and private sectors. There's some fantastic writings about the basics of multi-criteria decision analysis. There's some excellent writing in the health literature, but there's a vast broader literature on this. So if this is new and you're kind of thinking, oh, you know what, that looks interesting, just Google MCDA and you'll get literally a few 100,000 hits, and can start to, there's even an International Society of Multi-Criteria Decision Analysis, believe it or not. So there you go. The expected outcomes of this type of approach, getting at real resource shifts, and doing so that those shifts allow an organization to move closer to its strategic decision-making objectives. I've noticed time and time again that because we are introducing the concept of opportunity cost more explicitly in the priority setting process, that we're indeed bending the cost curve. We're moving decision makers away from the bun fights and the who can yell the loudest and get more resources in, to a place where we can weigh out explicitly, understanding the opportunity cost as part of that, where to shift and move resources, where marginal gains are greatest. Certainly, there's lots of opportunity in this for public involvement. It's a whole nother talk. Close colleagues of mine like Stuart Peacock, who used to be one of your colleagues, is now one of my colleagues just down the street here in Vancouver at the BC Cancer Agency. He's in the middle of some massive grants looking at how the public can be more directly involved in priority setting decision making. And so Sarah and John, I'd just invite you guys to reach out to Stuart and get his perspective in an upcoming webinar on that notion of public involvement in healthcare decision making, and then leading to greater transparency and accountability. And for me, I've yet to go into an organization the last few years where these concepts are not front and center of every decision maker's minds. And so allowing for greater transparency, leading to greater accountability. The approach that I'm talking about with PBMA and accountability for reasonableness has now been used in over a couple hundred organizations. Certainly it's got a fair bit of traction in the DHBs in New Zealand, at times in part due to Stuart's work, hopefully now due to Suzanne's work in Perth, and indeed in other states. Perhaps some of you on the webinar are familiar with or have been involved with some of the work in different states in Australia, and the UK, certainly with folks like Cam and Suzanne and Yeston Williams and others across the UK have been actively involved in this work, and obviously Gavin Mooney, who many of you will know, who passed away not that long ago, and was a big advocate of this type of work early days in the UK, and then when he moved to Australia a decade or more ago. And so the point of this slide is really to say this has got traction. It's used time and time again. Some of the evaluation work internationally has shown that in many cases, organizations, once they apply this type of work, this type of process, won't go back. They kind of look at it as, hey, we're seeing something better than the historical and political means of allocation, and it's allowing those organizations to get at many of the points I just mentioned on the previous slide. So that's really rewarding, right? Because that bottom point there on this slide, speaking to decision makers picking up a new way of thinking, understanding that reallocation becomes the name of the game instead of that always raising my flag and trying to get simply trying to get more resources. And in certain areas of the health system too, whether it's mental health or Aboriginal health or other areas of public health, I'm not saying that they shouldn't or are not deserving of more resources. So sometimes that flag of being an advocate for more resources does have to be raised. But what I am saying is that getting away from the notion of, as a whole, dramatically more resources should be invested in healthcare, and rather thinking much more explicitly about reallocation to live within our means and work towards the meeting of the system objectives that are at hand. So some of the lessons learned from the international literature, as well as my program of research within Canada. You can't do this without really strong leadership, and I found that in a few failed exercises where we've gone into an organization thinking that they want a new way of doing priority setting, and then finding that there wasn't the key leadership at the end of the day to see it through. Project management is actually a really important aspect, and people sometimes ask me, well, other than leadership, other than CEO support, what's the next most important thing to making this happen? And I'll say, honestly, give me your best project manager in the organization, and we'll be able to march through in a matter of months to transform the way of thinking and the practical application of resource allocation. You've got to have the criteria laid out and development of formal scoring tools to do the rating and ranking. Transparency is time and time again shown in our research to be the key driver of process fairness. As I said earlier, you can't do this without physicians on board, and I would extend that to clinicians, depending on the area of interest and the scope of the exercise. This does take time, and just back to Gavin Mooney, and one of the quotes that has always stuck to me that he made in one of his early books on this topic was, sure, it takes time, but actually for the decision maker, what's more important than determining how resources will be spent? So, sometimes decision makers do say, well, we don't have the capacity to learn a new method, or, it's difficult to do. Well, yeah, you know what? And it should be difficult to do. These are hard choices that have to be made. But decision makers don't hide behind the fact that it's difficult for something that's so important. You know what? There's always going to be the political aspects in the process, and I think we need to accept that and acknowledge that. I've found that having a formal process in place gives decision makers legs to stand on, and so when the political masters come knocking, they have that accountability. They have that, hey, you know what? We went through a process. These were our decisions. If you up the food chain up the political food chain are going to tell us we need to make a different set of decisions, we can accept that because that's the system we live in. But our process said we should be going over here. And more often than not, I've seen decision makers be able to push back to the political masters and have a different type of discussion than they would have otherwise been able to have had they just been relying on that historical allocation. So I mentioned we'll talk a little more about disinvestment. So we'll just spend maybe just 2 or 3 minutes on that now, and then we can come back to it in the questions. In Canada, we've now applied the PVMA approach in over about 50 organizations. And we've seen some pretty massive disinvestment savings that have come in through this type of process. And I think the key here is to think about disinvestment not just about assessing ineffective services. And the reason why I say that is that in my experience, many health service organizations have already over time evolved out of doing truly ineffective service. That being the clinicians and the practice guidelines and the activities on the ground, you're unlikely to see truly ineffective services still functioning in our system. And you look at, you can look at this in a number of ways, but the most obvious for me is just, technical efficiency has been a big push in the health service over the last decade. And many clinicians have been pushed on that. So, while the do not do lists and the choosing wisely approaches, I think have merit and would support continued thinking around those lines. My take on that is probably not going to get us all the way we need to go with respect to identifying disinvestments, either to meet deficits or to have enough internal disinvestments identified to reallocate into areas of potentially higher value service. And so looking at ineffective service, sure, but also looking at areas of lower value. So services that might be producing some benefit, but are producing lower benefit than other areas. And then hopefully you're thinking in your head, well, yeah, sure, Craig, that's easy to say, but how do you get there? And that's where you engage with the organization, you look at proposals for disinvestment at the margin that can be assessed against the criteria. And that's what informs you as to the relative value in relation to opportunities for investment. And this is just reflecting that in a little more detail, and some of you will be probably familiar, certainly if you worked in the health service, with a number of these points, whether it's outsourcing or the whole notion of Lean, Six Sigma, integration, consolidation, all aspects of fiscal constraint. Disinvestment gets at that notion of removing ineffective service, and then the furthest step for me that isn't as common is reducing lower value services. And it's obvious why that's hard, because people have an interest in their program areas, and if they're producing some benefit, they might argue that they should continue to operate. Well, you know what? That's not good enough in this world, and the private sector doesn't operate like that. Why do we allow, this is my little high horse, but why do we allow in the public sector some acceptance of mediocrity, when the private sector, sure, they have different criteria, different benefit, different outcomes. It's all about ROI, and that's fine. But in the private sector, they don't accept that mediocrity, or else they'll go out of business. Yet in the public sector, we seem to think, oh, sure, we can continue to produce, keep producing and implementing lower value service to produce, a mediocrity set of results. Well, why do we accept that? Because it's always been done? Because the clinician thinks it's important? You know what? If we do have constrained resources, we have to get over that and look at that really much more directly. All of what I've been talking about is can be supported online, and John at the front mentioned that I have the academic hat and as well a consulting hat with a prioritized consulting that I run, and this is just a link to our website and a software tool that we've developed, which can support the entire PBMA process, can be released within an organization, and walks the decision makers and the executive team right from training through to criteria development, proposal generation, proposal assessment, and then monitoring and tracking those proposals. So in addition to my book that John nicely flagged earlier, I'll flag that there's this tool available for folks if you want to check that out. So summary here before I just touch on maybe just one case study, noting the time and wanting an opportunity for questions. Lots of literature on this topic, and there's been lots of formal evaluation of the approaches that I've been talking about, and we see that notion of leadership as the real key success factor. I really do look at this as a tool to support better decision making. It provides a vehicle for getting evidence into the decision-making process. And again, while it doesn't remove the political aspects of healthcare, it certainly provides a greater accountability base. So I'll just touch on one case study from Vancouver, and then I'll close and we can have some questions and discussion. So within British Columbia, our health system is organized into 6 health authorities or health regions. Key aspect for those not familiar with the Canadian system is that our physicians are paid predominantly on a fee-for-service basis, and they are paid directly from the provincial government. So in no cases, or in very few cases, are physicians actually employees of a hospital or employees of a health authority. And that leads to some pretty dramatic challenges when you see that you've got the health authorities interested in minimizing cost and maximizing quality, sitting independently from the physicians who are paid on a fee-for-service basis, so they have a incentive to drive utilization and are indeed the key decision makers with respect to driving that utilization, but having no direct responsibility back to the health authorities. So it can lead to a perverse set of incentives, and indeed we often do see that within our context. Vancouver Coastal Health is one of those 6 health authorities, and it has approximately a $3 billion annual operating budget. It's a single entity governed by a single board of directors, and it's both a provider and a purchaser organization. So in our context, the organization receives funding, that $3 billion, from the Ministry of Health, and that as an entity, that single board of governors and that single executive team is responsible for allocating those resources across the full spectrum of services, right from community care through to tertiary care at the sites around the province. And it serves about 1.5 million people. So one of the portfolios or divisions within Vancouver Coastal Health is community services. And we, a few years ago, went into the community service portfolio to look at how the organization might face and address a large budget deficit that was not being able to be resolved with the usual means. And the usual means in this context were across-the-board cuts or some program evaluation work whereby individuals within, well-meaning individuals within the portfolio were trying to assess different aspects of the program against objectives and try to sort out where resources might be able to be freed up. In the end, the aim was to not only address the deficit that was in play, but also to identify areas for investment so that that reallocation piece could be part of the process. And interestingly, I was just at a meeting the other day with the chief finance officer at the time within Vancouver Coastal Health, who brought me in to assist with this process. And he just reiterated, he said, Craig, again, time and time again, when we've done this type of PBMA process within these large organizations, reallocation really has to be a part of it. Even if there's a deficit, even if there's a desire to meet a budget gap, for the people involved, you have to have that investment side of the equation. You have to get at that redesign, reallocation piece within the same process. And so if you have a deficit, that just means you've got to go that much further in identifying disinvestment, so you've got resources freed up to reinvest. We did this over about a 3-month process. So for those, who've heard about PBMA and have maybe in the past thought, ooh, it's really bureaucratic, it takes a lot of time, it's really challenging. One, with the software, it's not that challenging anymore. And two, it doesn't have to take a long period of time. You can do this in a very streamlined fashion, get the training done, get your criteria established, figure out what's in scope, generate proposals for change both on the investment and disinvestment side, and then have the advisory committee assess the proposals that have come in against the criteria, and then produce a series of recommendations for reallocation as already discussed. In this case, we did have the senior executive team was fully on board with us working with this portfolio. We had an advisory panel, and then we had a detailed working group, which was the one level that really rolled up its sleeves and looked at all the proposals. I put this slide up just to give you a sense of the criteria that are of interest, and because you're all in your computer screens, you can actually read this. Usually when I put it up on PowerPoint, it's impossible to see. So let's have you just take a minute to look at some of the key criteria that were being used in this case in Vancouver Coastal Health. Lots of things around access, equity, prevalence, client experience. We usually see 12 to 15 criteria that come up in these kinds of contexts. You'll note they're defined, and you'll note that they're weighted to reflect their relative importance. Came up with the proposals for investment and disinvestment, and in the end, we actually had about 55 proposals, which on average were about $100,000 in value. We had a number of efficiency gains, but as well, predominantly service changes getting at that concept of lower value services. And in the end, just under $5 million were recommended to move forward on the disinvestment side because they were either a strict efficiency gain with low risk, or they were of a lower value service area. And those resources were shifted against the deficit, and then as well some resources freed up for a small pool, a small but important pool of resources for reinvestment and moving into new areas. Lots of support for this, and in fact, this particular case, a number of the disinvestments related to some of the programs around one of our very challenged low socioeconomic status areas within the city in the urban core, and some vocal advocacy groups came out and were very much in the media, slamming the health authority for the decisions that were being made, and it was amazing. It went right to the legislature in Victoria, our capital in the province, and on the House, in the floor of our legislature, the health minister, who was taking flack from the opposition, actually said, you know what, Vancouver Coastal had a process. It was well-defined, it was rigorous, it evaluated all the options, and we're not touching this. And I thought, you know what, good on him, right? That he could stand behind the process and stand behind the health authority because they had a process in place, as opposed to just being swayed by the politics of the day. I'm just going to skip through the second case study. The slides will be posted on the website, so you can pick those up at a later date if you'd like. So 3 slides left for me. One, to say we've got this Priorities conference coming in Birmingham in September, and so please log on and take a look at this. And I'm on the organizing committee, as is Suzanne Robinson, and Justin Williams from Birmingham is spearheading it. So just Google Priority Setting Conference Birmingham, and you'll get to the right webpage. It's going to be a great few days of discussing priority setting in healthcare. And so that is where I'll leave it. This is a view of a part of the coastline just north of Vancouver, where my wife and our 2 girls were fortunate enough to do some kayaking this past summer. Pretty spectacular spot on the BC coastline. So I'll leave it there, and would love to entertain any questions, thoughts, comments from the folks on the line.
Thanks, Craig. That was great. Fantastic run through of the history and the process of PBMA, and some good examples there at the end. So I'll just encourage any participants with specific questions to type them into the Q&A box. But I might start. I've kind of obviously been aware of your work in this area, and PBMA and MCDA for quite some time. And I guess the issue I've always thought about is the data requirements.
Yeah.
And so have you got any comments on the ease of getting the data to inform the process, to inform the criteria, and whether you've got examples of where the data just weren't good enough or it caused problems with the process?
Yeah, absolutely. And honestly, John, I think that is the #1 question which comes up. Absolutely. And it's such a valid question, because the last thing we want to do is be introducing a process that we're calling rigorous and evidence-based, when in the end, in actuality, the data and the evidence aren't there to support the decision. So it's a great question. My answer is going to sound a little bit like hedging, but it really does come down to what's available within an organization, right? Something like Vancouver Coastal Health, a $3 billion entity, they have a whole wing of decision support, and they have oodles of data which you can tap into for this type of process. They've got finance data, they've got utilization data, they've got in-hospital, out-of-hospital, community care, multiple data sets that one can draw on to not only support your program budgeting activity, but as well have real data to support questions on the criteria that will come up around prevalence, potential impact, local application of information that you might see in the literature and want to figure out how to apply within a given context. So the big organizations in Canada anyways often will have ready access to the data that's needed, and more importantly than just the data, the decision support personnel to help the advisory panel navigate that well. Now, that's not the norm, right? I mean, Vancouver Coastal is probably the biggest health authority in the country. And I acknowledge fully that many organizations, particularly in the community care side, are going to struggle with data. And so where I come to there, where there is organizations that struggle with local data access, is to say, I would still argue that having an explicit process with the right people around the table is going to be better than the CEO and the CFO going behind closed doors and in their black box coming up with made up with their best guess on how resources should be allocated. And so where the data isn't available, what I've written on and what I'll often say is that group, that advisory panel is going to, of experts, whether that's clinicians, managers, maybe some members of the public, whoever is at that table, that group, will then be able to put their lens on the questions at hand, assess the proposals against the criteria the best way they can, draw in evidence from the literature, draw in local data where it's available, but make a pragmatic decision based on their expertise around the table. So I appreciate it maybe sounds a bit like hedging, but it does depend on what's available in the organization. And my main message is where their data is less available, where there's more limited data, it shouldn't stop us from trying to get in a more rigorous approach to priority setting.
And does the accountability for reasonableness approach incorporate some aspects around data quality and what's going to happen if the data isn't of high quality, and presumably the quality can vary across the programs or interventions being considered?
That's absolutely right, John. And so, if you've got a multifaceted set of programs that you're looking at, there will certainly be some areas where there's a stronger evidence base than others. And so the key for that advisory panel then is to not allow the amount of evidence in one area overwhelm the process in negatively impact those areas where there just isn't the evidence, but there might be some good ideas, and again, needing to put their own lens on that to make an assessment going forward.
Yeah. All right. Lisa Charwood's got a great question. She says, do you use qualitative data, e.g. Key stakeholder interviews, to inform on-the-ground drivers, barriers, facilitators, practice change?
Yes, absolutely. In many cases, we'll do that as part of the process. So that would come in, say, where the advisory panel's meeting, they come up with their criteria and they want to start generating proposals. And I mentioned that those proposals can be top-down. I don't like that. They are often bottom-up driven. And right there at that point of generating proposals, we'll see advisory panels holding focus groups outside of the organization, tapping into patients, tapping into members of the public, tapping into advocacy groups, tapping into different types of clinicians. You can use those the more qualitative methods to develop ideas, generate options that would then be inserted directly into the process. So absolutely, it becomes actually quite a key part of a well-run, robust process.
Great, thanks. I just had one more question, which was, I was interested to hear you talk about the appeals process. And clearly I can see how that would be an incentive to engagement and get people around the table. But can you give an example of what that appeals process involves?
Yeah.
And an example where it's been used, maybe?
Yeah, for sure. So it's there as a placeholder, and if it's not needed, it doesn't have to be used. Sometimes people like to use it because they didn't get their way, and so they'll raise the flag and say, hey, my program is getting shafted in this, we need to appeal. And the key is to have a very strict set of guidelines around what constitutes an appeal. And it's really two things. It's one, whether an argument can be made that the advisory panel misinterpreted some key piece of evidence that would have led to a change in how a proposal was rated. Or secondly, that new information has come to light in between when that rating was done and when the decisions are being done. And that's pretty rare. So really it's almost always in terms of, hey, you guys took your lens on it, but me and say this very special area of psychiatric care, I know this literature inside out, and in your interpretation of one of the business cases for one of the proposals, you are reading this incorrectly. Right, fair enough. That can be kicked back to the advisory panel with some explanation as to where those procedural errors were made, re-rated, re-ranked, and then recommendations changed if needed. I'd say, you know what, in the 50 or more that I've done of these, I've seen less than a handful, a single hand of appeals that have actually been put into a process. Because if you run it well, according to accountability for reasonableness, you shouldn't need the appeals. Yeah.
Okay, that's good to hear. Andrew Dalton asks, what have been the key methodological developments since you wrote your book in 2004?
Yeah, great, thank you. So a number of things. One, public involvement, and as I mentioned, Stuart Peacock and others are really leading that charge. So how to adequately and thoroughly engage the public in this type of work. I think the other one has been around further understanding and application of MCDA within this context. And certainly there's been a number of folks across Europe, folks like Rob Baltuzan, who has done some excellent work in this area. the application of MCDA. And then I would point to work that Suzanne and Justin Williams have done out of Birmingham around implementation and understanding, can we be all fine and dandy? And I've really focused on the parts of, the mechanics of getting to the decision, but the research that those guys have done has really pushed our understanding of, right, once a decision is made, how do we move forward with that? How do we get that implemented? How do we move the recommendations from being on a piece of paper or in a software tool into actual practice? And that piece of understanding has been a nice addition as well.
Great. Okay. Just one last question from Suzanne. I don't know if this was one that you got her to ask or not, but she's asking how important are clinicians, especially GPs, in the decision-making groups, and how do you engage these groups?
Yeah, the engagement piece so hugely important, and I talked about the senior level leadership being critical. I talked about project management being important. The third and really right in that top three group of key success factors is having adequate physician engagement. And how to engage them really depends on what the organization is and how it's structured. In many of the big health authorities in Canada, for example, we now are more and more seeing medical directors, so physicians built into the formal leadership structure. And then it's dead easy, right? Because they're already there, they have time freed up for administration, and they're sitting at these kinds of tables anyways. In organizations where you don't have that medical leadership built in, you've got to kind of wine and dine them a bit, right? Put on the advisory panels when there's food, maybe pay them an honorarium to get there. But however you get there, you can get them there. You've got to get them there because they're so important for moving forward on the implementation side. Okay, great. Thanks, Craig. So that's taken us bang on half past 11 here in Adelaide. So we'll call it a day. I always make the joke that we can't give you a round of applause, but Sarah, we should get a file or something with some applause that we can play. Natalie did leave a comment saying thanks Craig, that was a great presentation. It's given us some things to look into, so that's good. Oh, and Lisa's typed in applause. So so thanks very much, Craig. And just for everyone, the video will be uploaded onto the HSRAANZ website in the coming days, and the previous webinars are already there, so if you wanted to look at what we've hosted in the past, that'd be great too. So thanks, Craig, and hopefully we'll see you in Australia in not too distant. Look forward to it. Every time I'm down there, I don't want to come home, so look forward to getting down again, and thanks so much for having me for this hour. Really appreciate it. Thank you.
Thanks, Craig.
See you again.